This is the first lecture in a series of lectures on subfertility. We will be doing it in about 3 parts. So today we are going to cover the basics of subfertility. Mainly what we are going to cover are what do we mean by subfertility, why it is important, and then when we should really start investigations. Little bit about distribution or the background or the epidemiology of subfertility, and then we will see how physiological knowledge which we have gained in our first years helps us in managing and understanding a couple or humans faced with subfertility. Then we will have a brief look at the common causes and how we can prevent or identify factors which influence our fertility, what advice we can give, the initial assessment, history and examination, and then arriving at a working diagnosis or differential diagnosis based on our history and examination. In the next lecture we will talk about investigations in a proper way, and then in the third lecture we will follow up with the management and other options of the patients. So what do we mean by subfertility? Now, to define subfertility we need to know what is fertility. Fertility is the general ability of an animal or anybody to have capacity to conceive and produce an offspring. So humans generally has divided that ability to males and females. We know that sexual reproduction, based on that we have male factors and female factors, male eggs and female eggs, which unite in the reproductive tract to produce offspring. So anybody who is having a decreased ability or diminished capacity to conceive and bear offspring is having subfertility or infertility. I am using these two terms, infertility and subfertility, in interchangeable way, whereas there is another term which is related, which is called the sterility, which means that it is irreversible. The ability to produce offspring is not available or not there. So that is sterility. Whereas infertility and subfertility are degrees or variations of fertility, but still there is a hope or ability to conceive. So they can be used in interchangeably, but generally what we prefer is subfertility. Compared to infertility, this term says that it is less but it is not absent. Infertility, some people might understand it as equal to sterility, but definition wise it is still not in the dictionary, but people might take it as complete absence, whereas subfertility will give our message clearly that people are having less ability but still there is some hope. So the clinical definition of subfertility is that when you do not have the ability to conceive within 1 year of unprotected regular intercourse. So these are the key words. It has to be 1 year, unprotected, without any contraception, and in having regular fashion sexual intercourse. So if we don't meet those criteria, then it really cannot be subfertile. So a couple who meets on and off out of their fertility period, say once in every 3 months, even after attempting for 1 year, is not really subfertile because they have not really been attempting regularly for 1 year. Okay. So when you are managing patients, you need to see whether they really fit into these criteria. And then there are 2 other sub-classifications of subfertility. We have primary subfertile people and secondary subfertile people. those who are having primary subfertile are the ones who have had no previous pregnancy. The secondary subfertile people have been pregnant. It doesn't have to be a live, normal baby birth. It may have been a miscarriage, ectopic pregnancy, or even a molar pregnancy. They are all pregnancies. May be successful, may be unsuccessful, but still it is a pregnancy. So if somebody has had a pregnancy, whatever form, they belong to the secondary subfertile, even after 1 year. And generally when we handle, we wait for primary subfertiles up to 1 year, but when it comes to secondary subfertility, even 6 months sometimes we take as adequate try. Why is subfertility and that sphere is important in our day-to-day clinical practice? We know that human reproduction is not a very efficient process compared to other animals, say pigs, rats, cats and other all animals. Generally they don't have much difficulty in producing. But as we go up on the evolutionary tree, higher order animals, especially mammals and higher order primates, have a fairly reduced ability to reproduce. Probably because to upkeep or maintain one person, a huge part of the ecosystem has to work. Maybe because of that. We really don't know why that our process has become somewhat inefficient and a lot of wastage occurs down the line. But still, it is not fantastic. The ability to give a live birth within one menstrual cycle, which is defined by the term fecundity, is in humans is maximum is about 25% to 30%. And even when they are pregnant, 50 to 60% of all conceptions will not go beyond 20 weeks. Majority will, say, close to 50% or 40% will die before reaching full term, beyond 20 weeks. So majority will not go beyond that. They will not do that. So because of that, even physiologically infertility is a common problem. In countries where fertility data is available, the prevalence of infertility between reproductive age group of 15 to 44 years was around 9%, 8.5%. That is in 1992. Even on a repeat survey in 2002, it's still around 7.4. So now between 7 to 9% of population is having this problem. Even in Sri Lanka, rough estimates are on that range. So we can say roughly about 10% of the population will have some problems. By clinical definition, it is about 9%. But if you use a different demographic survey-based definition of absence of children after 5 years of marriage or attempting, then primary subfertility is around 2%, secondary subfertility is around 10%. So your statistics depend on the way you look at the population. If you go by the clinical definition, then it's around 9% or so. But if you go by absence of children after 5 years, primary is about 2%, secondary is about 10%. So quite a large number of people are really having secondary subfertility. Then we have data from all over the world described as a graph. This is somewhat old, about 10 years old, but still you can see different parts of the world have different rates. Partly it is because of the reporting problem. Most of the countries don't have proper data. For example, Sri Lanka, we don't have national registry of subfertility, we don't have national data. These are all estimates taken from various small sample surveys or hospital-based data, which is not the correct picture. In South Asia, you can see about 2%. In high-income countries, about 1%. The world over, everything put together, it's about 1.5. We can see Middle Eastern countries have a fairly high subfertility rate, and South Asia, like us, have another high rate. So when should we really start investigating? Based on our definition of subfertility, we really need to wait for 1 year. But as always, there are no hard and fast rules in medicine. We might start investigations a bit early, especially if the female is older. We know that female fertility is the main determinant of a successful outcome of a pregnancy. We know that after 35 years of age, a female's fertility start going down. So if the woman is about between 35 to 40 years, you might start treating or attempting investigations after 6 months. If the woman is above 40 years, go for your investigations the moment they present to you. Why is that? If you take a young healthy couple, say of 25 years, which is generally considered the peak age for fertility, if they attempt every cycle, every month, roughly around 50% will conceive. Half of those, say if you take 100 couples, by around 3rd month, 50% will conceive. By 6 months, about 70%. By 1 year, about 90% will conceive. So by this is the general dynamics of a couple. So cumulative conception rate, you add each month's success to the rate. The cumulative conception rate of 1 year is about 0.9 or 95. 95% of them will conceive. If you wait another year, another 2 or 3% will add, say by 2 years about 97 will come. So even after 2 years, another 3% still will be remaining. So those are the real people who need attention. That is why we limit our waiting for 1 year. So majority will conceive if they are healthy and young. But the picture changes when the couple is older. So the previous chart matches the one which is here. Somewhere there. Under 25, even higher fertility probably. So this is the chart which matches the previous. But if the female partner is between 31 and 35, you can see the second line here, which is even after 1 year, their fertility is around 60%. So if the female is older, only 60% compared to 90% in a younger couple. If the female is above 35, it's even worse. At 1 year, only roughly around 45% will conceive. So you can see, as the female partner gets older, there's hardly any good in waiting. You need to jump in and start treating because your fertility goes off. So advice which you can offer a young, older couple is just getting married at 35 years is to start, if they are planning for pregnancy, to go for pregnancy. This is another view. The whole reproductive lifespan, if we taken into one, which this shows the reduction of natural fertility of a female with increasing age. So if we take quantitatively, red line is quantitatively, that means the number of follicles on this side, and they increase, so the availability of embryos with aneuploidies or abnormal embryos, trisomies and others. This is the number of follicles. So you can see at birth we have the highest number of follicles, and then as we become older, roughly around menarche, which is around 11-12 years, it's somewhere there, and then as we go older and older, it becomes less and less, By the time we reach menopause, we have less than 1,000 or even less. And majority are not really viable. Qualitatively, the blue line, your fertility is fairly static from around 20 or from menarche until about 25. And then your number of follicles, while it is coming down, the risk of having abnormal baby increases gradually. You can see by around 35 years it starts increasing. That is why we plan all our prenatal diagnosis for Down syndrome and everything around 35 years. It was the traditional cutoff. You can see it exponentially rises by 40 years. It's fairly high. Around 70% of the embryos will be having abnormality, whereas at 35 probably about 30%. When you go beyond 45 or 44, 43, 44, roughly around 85 to 90% of them will be abnormal. So you can see beyond 35 also the risk of aneuploidy increases, which we have seen in the previous lecture about prenatal diagnosis in a tabular form. This is the same data in a graphical form. So optimal fertility starts around 18 years up to about 31 years. That's the period of optimal. Beyond 31 up to about 40, females' fertility declines. 41 to 45 also, you are in the borderline, your fertility may be ending. And then you start having irregular cycles, and then you go through the menopause. When you have irregular cycles, you should know that your chance of conceiving is less and less. So those are the things which you will use to counsel an elderly couple who is coming to you for fertility advice. As a doctor, these are the things which you should tell. There are other background things which you will discover in history, which will help you to decide on early referral. We talked about female fertility about 35, the age of 35 years or more, or at least after 6 months of trying, you need to think about referring them. Previous ectopic pregnancies, previous PID or tubal damage or history of pelvic surgery, STD, say gonorrhea, chlamydia history, suggestive of even that history is enough for you to send them for investigation. Anybody having oligomenorrhea or irregular cycles or periods of amenorrhea, again, better to look into them. People who have fairly big fibroids, not those small sub-zero cell fibroids, but submucous or large intramural fibroids needs removal. So anybody with anything suggestive of them having any wish for pregnancy, you need to refer. In males, maybe testicular maledescent, any testicular surgery, trauma, oculopexy, orchitis, post-mumps orchitis, anything, herniorrhaphies, which we will discuss in the history, anything to do with scrotum or inguinal canal, radiotherapy, chemotherapy in that area, any previous urogenital surgeries, STDs, very prominent varicocele. If you have no examination you detect, you need to send them for investigations. Then you have, we'll look at what is the general distribution or what is the epidemiology of subfertility. We have looked at the incidence and the worldwide prevalence data and the definitions. But everything about how we identify your epidemiology depends on the definition or the yardstick which we are using. As you would have seen, any disease definition depends on the way you look at it. Same with subfertility. So if you go by the clinical definition, after 1 year, roughly, if we look at a couple's lifespan, at least 25% of the couples will tell you that they have had some difficulty in achieving their desired. They may be living with 1 child or 2 children, but they may have wished for more. They may have attempted but given up on the way because they were not successful. So those are also people with subfertility, maybe secondary subfertility. So getting at the real picture of subfertility is not very easy. You can't really ask everybody on the road whether they are happy with their family size, or are they still wishing for children. It is very difficult. So we don't have really properly conducted survey data to identify epidemiology at the community population level data. All what we have is people who are coming to us with to the hospitals or the specialist practices presenting with subfertility. Only half of those who have the problem really will present to us with the problem. So we need to look at the fertility rather in a different way, or in a better way than just going by the clinical definition of 1 year of trying. If we look at fertility for inability of a couple to have a baby or pregnancy after 1 year, this is like classifying a population of people into 2 groups, say short and tall, depending on the measure. Say if we take 4 feet and 10 inches as a cutoff, below that it is short, above that it is tall. It's like treating a continuous variable, which is the height, as a dichotomous variable, or dividing into 2 groups, short and tall. But fertility is also a continuous measure or continuous variable. Each person or a couple can have different degree of subfertility. Everybody may be not having 100% fertility. They have a little bit of subfertility in the male partner, but the female partner may compensate and have a better fertility. So as a couple, they may be achieving a pregnancy or fertility. So by going by the definition of having a pregnancy within 1 year may not really reveal the real fertility of an individual or a couple. So because of that, the inability of our clinical definition to reflect or show the proper wide range of different degrees of fertility potential, we need to have a different term to describe or express fertility. So we have gone to statistics or the probability descriptions of fertility. So the best term which we can use to define or tell or express somebody's fertility is usage of term called fecundity and fecundability. Fecundability is the probability of achieving a pregnancy in 1 menstrual cycle. Remember, this is a pregnancy, not a live birth. Whereas fecundity is the ability to achieve a pregnancy result of a live birth. So if you are talking about a live birth per cycle, then it is fecundity. Fecundability is any pregnancy within 1 cycle. In a healthy young couple of about 25 years of age, this brings about 0.25 to 0.3, 30%, 25% to 30% in young couple. Fecundability is a population estimate. So it is based on the total population. If you take 100 people of 25 years, if we keep them having regular intercourse, after 1 year, 95% of them will be pregnant. That is their fecundability. In 1 cycle, 0.25 of them will be pregnant. So this, based on this clinical characteristics, we can estimate the fecundability of a person or a couple on a range, say 0 to 1. So it can be 0 in completely azoospermic male, in a female of endometriosis 0.4, a couple with difficulty in achieving penetration, it may be 0.05. Like that, we can put their fertility on a range of 0 to 1 at different degrees, and this we can juggle around with these by various estimations. So we can have qualitative as well as a quantitative estimate of a fertility. And this makes our life as doctors easy, because we can estimate the effect on our treatments. We can offer them a better choice. Suppose say we have a couple who has an estimated fecundability, or say after going through their history and assessing everything quantitatively, by formula we have come to estimate their fecundability or ability to have a pregnancy in single cycle as 0.04. Now we have two treatments. One is to go for straight away for IVF. The other treatment is to start inducing with comifene citrate and then for intrauterine insemination or IUI. So the low cost IUI and comifene treatment will increase their fecundability of 0.04 to 0.08. Whereas IVF, obviously because it's more advanced, will increase the fecundability to 0.2, 0.25. But the downside is it's 10 times more expensive, or even 100 times more expensive than the low cost IVF. So you can give the choice. You have 0.04 chance of getting a pregnancy in one cycle. If we do this treatment, it can be doubled into 0.08, or it can be tripled by IVF. Downside is expense, but you can decide. So you can discuss in a more intelligible manner with the couple if you use this term of fecundability. So that is something which you will come to terms, because in future we will not be just advising couples as they come along. We will be discussing the pros and cons and everything, and in advanced reproductive clinics, these are the way the patients are handled, rather than just giving a prescription for ovulation induction, which is what most of the time which we do is not the ideal way of handling. You discuss, you provide the information and then discuss with them various outcomes, how it will improve their chances, and then come to a calculated or accepted treatment based on their understanding. So it improves our discussion, and you can always give them an estimate of their per cycle pregnancy rate. So if you attempt one cycle, your chance of pregnancy will be like this with this treatment. So it gives a better confidence to the couple as well. So that is epidemiology and better terminology for description of fertility. Now we will come back to our physiology. Human fertility is mainly based on the ability to meet the sperm in the oocyte in the female reproductive tract. So if we go with this and blow up the diagram, the male contributes only the sperm and deposits in the vagina. Then the sperm has to travel up, go to the ampulla, and there you meet the oocyte, which comes from the ovary. So down this path from the ovary, or from in the male, in the case of male it's the sperm, if there is a difficulty, we will have problems in achieving a pregnancy. So if to start with the ovary, if the ovary is not producing and developing normal follicles, maturing them and releasing them in the ovary, and from the ovary into the peritoneal cavity, and then tapped by the ampulla cilia at the end of the tube, taken in, and then carried on the fluid of the tube into the fertilization site. And if they don't meet the sperm there, then it will not fertilize. If you meet the sperm in the middle of the tube, it will not really be fertilizable. So you need to have the fertilization in this particular part of the tube. So people who have tubal damage or part of the tube taken away by previous ectopic or whatever will not result in a proper pregnancy. If you have a blocked tube, most of the time you will land with the ectopic pregnancy. So previous PIDs, chlamydia infections, tubal surgeries, pelvic injuries, all will end up with a problem in pregnancy. People who have blocked tubes again are likely to have difficulty in either allowing the sperm to swim to this part to fertilize a pregnancy, a human oocyte, or even on their way back to the uterine cavity, they can get stuck. The zygote can get stuck and then end up with ectopic. After fertilization, they take about 6 days to reach the tube. The zygote takes about 6 days, and on the 7th day it is in the cavity, and then it will float around 1 or 2 days, 7th to 8th day in the cavity, and then it decides to implant. So this fertilization to cavity, that period has to be roughly around 7 to 8 days. During this period, the developing zygote will communicate with the decidua of the endometrium. So by the time it reaches the decidua is ready. Suppose if the zygote is carried too rapidly to the uterine cavity, it will not be in the cavity in the proper time. So if the timing is not met, it will not implant. So the failure to implant is something which we generally don't consider too highly, but that is the reason why most of these unexplained infertile people are not having a pregnancy. So the fertilized zygote will have to reach the endometrium in the properly timed manner. If it's not reaching the endometrium in the proper time, it will not. So there is an implantation window concept which needs to be met to have a successful pregnancy. This is like this turtle's tail. It has to look at the sun on a particular day, otherwise it will not see. And then uterine abnormalities on the uterus might also impair the ability. We know that the proper site of implantation, the majority of human pregnancies will implant on the posterior upper fundal area of the uterus. So if we don't implant properly on that day, you will not have a pregnancy. So if you can recall this, you will note that having a pregnancy is not a very easy thing. So for the male also, problems at the cervix, the cervical mucus becoming thick and impenetrable will not be that helpful to achieve a pregnancy, and then having enough viable sperms which can swim up the tract up to this level will have to be there. So if the motility is low, obviously you will not. If the number is low, the number who are reaching the implantation, so fertilization site, will not be adequate. So there are various blocks down the line. So physiological state of achieving a pregnancy is very difficult. And then while developing, there is a possibility of various arrests of embryonic development. Most of our miscarriages, which even after implantation will end up ending up with miscarriage because of this failure in arrests of various stages of embryonic development. So when somebody asks you why they are ending up with a miscarriage, you need to tell them that it's a complex process. So any time at any given particular point, there can be problems and you will end up with a miscarriage. I'm not going into detail about female side hormonal cycles, endometrium changes, but if you can recall your pituitary hormone profile in the menstrual cycle, ovarian hormonal cycle, changes of the cervical mucus, you can see that during the ovulation, cervical mucus viscosity increases and volume reduces, so it becomes thin, low volume cervical mucus. So the volume reduces, it's not that thick, viscosity increases with fluidity, so allows the sperm to travel through the cervical mucus. The basal body temperature is based on this monitoring. We know that in the luteal phase it's 0.4 or so high in temperature due to the progesterone effects. And the resultant of all these estrogenic and progesteronic activity is the changes in the endometrium. So if you are a bit hazy on this area, please revise your physiology and histology notes. Then we come to the common causes of infertility. If we classify everything together, we have about 30% of male related causes, another 1/3 female, so roughly 1/3, 1/3, 1/3, and another 1/3 can be both or unexplained. Majority, about 25%, 1/4 of couples, we can't really attribute to the common reasons. They end up having unexplained infertility. Both partners' identified causes may be in about 10%. Another 5% will have other reasons, say proper not timing the pregnancy or attempting an intercourse properly may be the reason why they are not achieving a pregnancy. Other factors which contribute to fertility are most of the time male factor. Ones like low amount, low counts, abnormal motility, morphology may be the reasons. In the female partner, if the female is older, the ovarian reserve, the number of viable, good quality ova available on ovaries. So if the female partner is older, in present context, before embarking on treatment, we will get their ovarian reserve or ability of their ovaries to have a viable ova is assessed. We will come to the various ways of assessing ovarian reserve later in investigations, but we need to do that. If the female is about 35 years, generally their oocyte quality is low and their reserve is less. And then lifestyle of a couple, smokers, overweight to underweight, alcohol usage, drug intakes, medicinal drugs, as well as recreational drugs, cocaine, heroin, amphetamine usage, stress, lifestyle stress or work-related stress, again they are all contribute. Exposure to environmental pollutants. This is a big topic. Endocrine disrupting molecules, estrogens and other similar molecules are having a huge impact on our fertility. Most of them are added to our food or come to us in various other forms and get into our body and then influence our fertility. So we need to, as doctors, advise our young couples who are attempting a pregnancy to avoid them. I have put up another small note in the Moodle about endocrine disrupting chemicals. Please go through them and use those points to advise your patients. Heavy caffeine intake. If you take more than 2 cups of black coffee per day, especially the female partner, it might impair your fertility. Various tubal function defects. Say, tube may be patent. Most of the time what we assess in tubal factor infertility is a patency. Patency doesn't mean anything. Tube is a complex organ. It needs to facilitate transport of sperm and it needs to take the ovum from the fertilization into the back into the cavity. It has a flow counterflow system like in the tube of Henle. Same thing happens in the tube. Fallopian tube as well. So it's a complex environment which is very difficult to mimic or repeat. So because of its complexity only, we have IVF. So scientists tried to correct fertility, tubal infertility, they couldn't. So they completely took the processes which happen in the tube and taken it into the lab to allow fertility. So to mimicking or repeating the tubal function is very difficult. It takes years of research to develop the fertility protocols on IVF. So any problem with the tubal motions, tube muscular activity, ciliary motion will impair your fertility. And then even after reaching the sperm may have difficulty in developing acrosomal reaction, which is necessary for it to penetrate the zona pellucida of the ovum. If the sperm DNA is damaged, which is again due to these various environmental toxins damaging pesticides and other things damaging the sperms. Females with the very advanced age, again, they can have problems with their sperm functions. Various testicular oxidative stresses due to chemicals and drugs may be really influencing the fertility. Then when it comes to implantation, I have mentioned briefly earlier also, various inflammatory mediators, cytokines and other interleukins and other chemokines impair. So anybody who is having an infected endometrium obviously will not conceive because of these effects. So any signs of infection needs to be treated first before attempting a pregnancy and allow it to heal properly as well. So after treatment immediately you can't start treating, you need to allow some time for them to get pregnant. Various metabolic factors, immunogenic factors, endometriosis, fibroids, adenomyosis, they are all factors. This gives the same data in a bit orderly manner: ovulatory, fallopian tube, uterine and oocyte quality in the female partner, and in the male partner, obstruction to the tube, the path of the semen, non-obstructive causes like Coleman syndrome, testicular failures, endocrine background, and functional causes like erectile dysfunction or premature ejaculation. Again, are all factors which then people with unexplained infertility may have fertilization defect or implantation defects, or problems with chromosomal component like translocations and other things, as well as infrequent coitus. So all these things are important when you are assessing. We will come to the history in a few minutes. Those are important. So how can we prevent infertility? So these factors which influence fertility has to be reversed. So you need to, in the male especially, reduce their estrogenic pollutants in their diet and the environment. If they are working in farming or other chemical industries, get them into a place where they get exposed less. If they have undescended testes, get them to have orchidopexy surgery. Avoid, when you are doing any surgery on a male, especially young males, avoid injury to vas deferens or to the testes. If you are having a risk of orchitis, especially this due to mumps, think about MMR vaccination even in males. In the females, anything to do with unwanted infections or terminations in pregnancy should be avoided, because that will damage or cause infection in the endometrium on the tube and can impair their fertility. Any female with abdominal pain has to be treated with utmost respect, especially if they are young, because their tubes or the pelvic organs can get damaged and you will end up with a fertility issue. Then you can have, in both partners, STDs has to be treated vigorously and actively, and then when they are planning a pregnancy, that their tubes and other functions has to be assessed early. One advice you can give everybody is not to delay attempting a pregnancy. If you are going for surgery or radiotherapy or chemotherapy for any malignancy, store sperms in males and oocyte or cryopreserve the oocytes in the female. Exposure, occupation to pesticides, heavy metals, lead and other radiation exposure, heat exposure, you need to avoid. So depending on each person's background, you need to advise. So these are the things which we can probably do to help. What do we do when a couple is coming to us with planning for pregnancy? Go through their history, check their understanding about the healthy lifestyle factors which can impair their fertility, diet, exercise. You need to discuss and get some idea, and then guide them towards the healthy practices, lifestyle improvements. You can assess their individual law, personalized fertility knowledge and the fertility background. There are tools like Fertistat which you can use. This is a website which is sorry, it's not connecting, but it is a site. You can click on the link which I have given in the model and come to that website. It will tell you about the fertility assessment. A questionnaire is there that will tell each individual or female partner about their fertility level and the factors which they need to improve. So that can be very useful in counseling. And then depending on their BMI, you can advise them to reduce their BMI, cut down on smoking, and stop recreational drugs completely. If they have any pre-existing medical conditions, stabilize, control, and reduce whatever drugs they are on, if it is possible, depending with the physician's advice. Recommend folic acid, especially if they are having anti-epileptics or any drugs which is impairing their folic metabolism. Advise them to take higher dose, like 5 milligrams of folic acid. If they have not been immunized, encourage rubella immunization and others, and screen for HIV, Hep B and Hep C if they are at high risk, sex workers or people who have gone abroad. Check those things and advise vaccination. And if the woman is older, you may have to discuss about possibility of offering prenatal diagnosis the moment they go get a pregnancy, or if they are going for IVF, about pre-implantation diagnosis. Check their knowledge about ovulatory cycle, and then give them advice about timing of intercourse, roughly about 2 days prior to ovulation, say in a cycle of 28 days, which will be around 10th day onwards, because ovulation roughly occurs around 12th to 14th day. So 2 days before means 10th day and onwards, roughly for about 4-day window minimum. So around 2 to 3 times a week during that particular window period would really be helpful in achieving a pregnancy. Then we come to the last part of today's lecture, evaluation of a couple. So it is basically the history and examination. In the female partner, there are certain questions which you need to ask and then do the examination. The details of this are available to you in the model. I have put the subfertility clinic record which we are using at Peradeniya Prof Unit Clinic. You read that and then start taking the history based on that. Then you will cover almost everything which I am mentioning here. So rather than going through the lecture note, always practice and then it will stick in your brain. So first and foremost, you need to ask how long they have been trying, whether their intercourse and the timing is correct, and then whether they have been in pregnancy previously. Go through their gynae history, pelvic infection, surgery, or whether they are having any dysmenorrhea or anything, or dyspareunia, which suggests a PID or endometriosis, are important. Previous medical history, treatments, medications, all are important. Diabetics or epileptics needs control as well as optimization. Previous pelvic surgeries, their background, family history, polycystic ovarian disease, thyroid diseases, obesity, or family history of congenital abnormalities or recurrent pregnancy losses are very important and have an impact on the patient's fertility, as well as family history of cancers. So based on the history, it will tell us something about their fertility potential. Say if somebody has irregular periods, they may be having ovulatory problems. So you need to think about offering them proper full endocrine evaluation of thyroid functions, FSH, LH, testosterone to rule out, and prolactin to rule out influence on the ovulation. Previous chlamydia infection or hospitalization for PID or BSE, that would have damaged the tube. So you need to check the tube. People with irregular bleeding or menstruation or heavy menstruation may be having a fibroid somewhere, endometrial polyp may be there. So you need to plan evaluation for those. Then when it comes to examination, general examination for BMI, height, weight, obesity, evidence of anorexia, evidence of PCOS, evidence of thyroid disease, you need to think. Tachycardia, bradycardia may indicate a thyroid problem. Head and neck examinations, cervical lymphadenopathy, galactorrhea, Tanner stage, abdominal scars for previous surgeries, that will give you information. So doing a proper general examination and abdominal pelvic examination will be helpful. Say bimanual palpation is essential for you to identify any abnormality in the uterus and the ovaries. PR examination, rectovaginal examination will help you to identify rectovaginal septum endometriosis or pelvic adnexa. Skin for evidence of hirsutism, acanthosis nigricans will help you to identify PCOS. So based on history, you might come to diagnosis of PCOS or endometriosis or PID, depending on your examination. Or you may come to a working diagnosis. Same with male. Previous pregnancies with another partner, how long they have been attempting, previous infections, timing of intercourse, whether they are using lubricants, what sort of lubricant, because some lubricants which you use like KY jelly are harmful. Even the lubricant which is available on the condom is harmful. They are spermicidal. So if you are thinking about advising somebody to use lubricant for intercourse, then it has to be vegetable oils or plant-based oils. Canola oil probably is best. And there are other custom made preparations as well available on the market, but definitely not KY jelly or petroleum based lubricants are generally bad, and water based lubricants are bad. Even saliva is bad as a lubricant. And then various diabetes and other infections, obesity in the male, and then medications and drugs, you need to think. The history of any other illnesses like cystic fibrosis, diabetes, polycystic kidney diseases, evidence of any Klinefelter syndrome, thyroid diseases, all these you need to check in their history. Drugs, the list is huge, so I'm not going into detail, but look at the drugs which impair fertility. So better to go through this list leisurely and think about their importance in your history of the male part. Surgical history of any torsion, hernia repair, orchidectomy, orchidopexies, TURPs, retroperitoneal surgeries, important. Social factors, lifestyle factors are important in fertility. We have discussed them earlier. So alcohol intake, drug intake, if exposed to heat like a cook, or people who are generally frequenting saunas or hot tubs, firefighters, may be exposed to heat and radiation both, need to come into that. And then as a routine, both in male and female partner, you need to have some idea about their strength of relationship, whether they are committed to each other, or if you are after treating, if you encounter pregnancy, then will they be sticking together to look after the baby, because you need to look after the welfare of the unborn baby as well. So you can't produce a baby and then the baby is not being cared by anybody. That's not good. So in other countries, before offering IVF, they need to have reports and supportive evidence from the church and the police station about their relationship and whether their family is stable. If not, they will be referred to counselors, marriage counselors, before offering treatment. So we need to develop something on the same lines before offering IVF and other procedures in this country as well. Then the family history of hypospadiasis, Cartier syndrome, or other congenital defects may be important. If there are the siblings, whether they are having the same symptoms, you may need to know. That is the history. it might help you to come to various differential diagnosis. And then examination, again in systematic manner, height, weight, BMI, evidence of gynecomastia, and then look at their genitals, look at the penis, urethral meatus. If it is hypospadiasis, it may be very difficult. Unless you retract the prepuce, you may not see it. Then check the volume. If you want to assess the volume, you need to use a oxidometer properly. If it is less than 25 ml or 30 ml, you need to think about hypogonadism. And then look at the male pattern of hair distribution. If they don't have proper male pattern, there may be hormonal irregularity. And any irregularities of the surface of the testis may indicate the presence of a tumor. Remember, if you don't examine, you may not diagnose it until its later stages. So you need to palpate the testis as well as the vas. People with agenesis of vas deferens will not be fertile. So you need to check. Without palpation, you will never identify. Your SFA will tell that's azoospermia, but the cause may be absence of vas deferens. So you need to identify that. Then check the epididymis, whether it is indurated, full or nodular. There are signs of previous infections or due to obstruction. And then palpate the cord and see whether there are varicoceles or lipo. And then do a PR examination to identify prostate or enlarged seminal vesicles which are due to blockage or infection. And depending on these, you might come to say, small tests might say hypogonadism. Absence of vas deferens may indicate cystic fibrosis, which you can confirm by looking for the cystic fibrosis gene. Or enlarged or nodular epididymis may indicate a previous infection, maybe due to obstructive azoospermia. So those are the things which you will come to differential diagnosis after the end of the history and examination. And in the next lecture, we will see how we are going to check or assess both male and female partners with various investigations.